Assalamu alaikum and a very good morning, students. You all know me. I'm Dr. Sifat Syeed, Assistant Professor, Department of Pathology. Today, I will start with a new system, that is respiratory system. Let's start with respiratory system. At first, we will go through the congenital anomalies of respiratory system. The first one is pulmonary hypoplasia. Pulmonary hypoplasia is characterized by defective development of both lungs, resulting in decreased weight, volume, and acini for body weight and gestational age. It may result from congenital diaphragmatic hernia or oligohydramnios. The next one is foregut cyst. It arises from abdominal detachment of primitive foregut and located in the hilum or medial mediastinum. The next one is pulmonary sequestration. It refers to discrete area of lung tissue that lacks any connection to the airways and has abnormal blood supply. It may be extralobar or intralobar. So the major congenital anomalies of respiratory system includes pulmonary hypoplasia, foregut cyst, and pulmonary sequestration. Then let's discuss about acute lung injury and acute respiratory distress syndrome. Acute lung injury, also called non-cardiogenic pulmonary edema, is characterized by abrupt onset of significant hypoxemia and bilateral pulmonary infiltrate in the absence of cardiac failure. That is, acute respiratory distress syndrome or acute lung injury will occur in absence of cardiac failure, and there will be sudden onset of significant hypoxia. Acute respiratory distress syndrome is a manifestation of severe acute lung injury. The conditions that are associated with ARDS includes infections, which may be sepsis, diffuse pulmonary infections, gastric aspiration. Then physical injuries may include mechanical trauma, including head injuries, pulmonary contusions, near drowning, fractures with fat embolism, burn, ionizing radiation. Then inhaled irritants may contain oxygen toxicity, smoke, irritant gases. Some chemicals may cause acute respiratory distress syndrome. These are heroin overdose, acetyl salicylic acid, and barbiturate overdose. Then some hematological conditions may be involved. There may be involvement of disseminated intravascular coagulation, pancreatitis, uremia, cardiopulmonary bypass, and hypersensitivity reaction. Now we will discuss about the obstructive and restrictive lung diseases. What do you mean by obstructive lung disease? Obstructive lung diseases are characterized by increase in the resistance to airflow due to partial or complete obstruction at any level from the trachea and larger bronchi to the terminal and respiratory bronchioles. But in case of restrictive lung disease, these are characterized by reduced expansion of lung parenchyma and decreased total lung capacity. So, in case of obstructive lung disease, there will be airway obstruction which may be partial or complete, and the level will be from the trachea and larger bronchi to the terminal and respiratory bronchiole. But in case of restrictive lung disease, there is reduced expansion of the lung parenchyma. Now let's go through the disorders that are associated with airflow obstruction. The major obstructive lung diseases include chronic bronchitis, bronchiectasis, asthma, and emphysema. In case of chronic bronchitis, the anatomic site of involvement is bronchus. Major pathologic changes will be mucus gland hyperplasia and hypersecretion of mucus. The main etiological factors are tobacco smoke, air pollutants, and the symptoms will be cough and sputum production. Then bronchiectasis. The anatomic site is bronchus. There will be major pathological changes are airway dilation and scarring. The etiologies include persistent or severe infections, and the sign symptoms include cough, purulent sputum, and fever. In case of asthma, the anatomic site of involvement is bronchus and terminal bronchioles. The major pathological changes are smooth muscle hyperplasia, excessive mucus inflammation, and etiologies include immunologic or undefined. And sign symptoms are episodic wheezing, cough, and dyspnea. Then emphysema. The site of involvement is acini. There will be airspace enlargement and destruction of the alveolar wall. The main etiology is tobacco smoke, and the main sign symptom is dyspnea. This is a photograph showing the anatomic site of involvement of chronic bronchitis and emphysema. In case of chronic bronchitis, if there is involvement of large airways, that is trachea and bronchi, there will be mucus hypersecretion and inflammation. And if there is involvement of small airways, that is bronchioles, there will be peribronchiolar fibrosis and airway obstruction. Now, in case of pure emphysema, there is involvement of acinas, that is respiratory bronchiole, alveolar duct, and alveoli. There will be loss of elastic recoil. Now, we have already known that the major obstructive lung diseases include chronic bronchitis, bronchiectasis, asthma, and emphysema. At first, we will discuss about emphysema. What is emphysema? Emphysema is characterized by irreversible enlargement of air spaces distal to the terminal bronchiole, which is accompanied by destruction of their walls without obvious fibrosis. So in case of emphysema, the airspace dilation will be irreversible and the area of involvement will be distal to the terminal bronchiole, that is respiratory bronchiole, alveolar duct, and alveoli. There are 4 types of emphysema. The emphysema is classified according to its anatomic distribution within the lobule. Based on the segments of respiratory units that are involved, emphysema is classified into 4 major types. What are these? The number 1 is centri-acinar or centrilobular. Then the second one is pan-acinar or pan-lobular. Then distal acinar or paraseptal. And the last one is irregular emphysema or airspace enlargement without fibrosis. This is a picture showing the normal acinas. Here we can see the respiratory bronchiole, then there is alveolar duct, then this portion is known as alveolus. In case of centri-acinar emphysema, the proximal portion of the acini is involved, but the distal portion is normal. Whereas in case of pan-acinar emphysema, the whole acini is involved. Centri-acinar or centrilobular emphysema. This is the most common type of emphysema. More than 90% emphysemas are centri-acinar or centrilobular emphysema. It occurs predominantly in heavy smokers and often is associated with chronic bronchitis. In case of centri-acinar emphysema, we have already seen from the picture, that is there is involvement of the proximal part of the acini, which is formed by respiratory bronchioles, and the distal part of the alveoli are spared. So both emphysematous and normal air spaces exist within the same acinas. Here in the picture we can show that the emphysematous portion of the airspace and non-emphysematous portion of the airspace exist in the same acini in case of centri-acinar emphysema. So it more commonly occurs in upper lobe, particularly in the apical segment of lung. Pan-acinar or panlobular emphysema. The acini are uniformly enlarged from the level of the respiratory bronchiole to the terminal alveoli. So the whole acini will be involved in case of pan-acinar or panlobular emphysema. More commonly occurs in lower zone of lung and in the anterior margins of the lung. And it is associated with congenital alpha-1 antitrypsin deficiency. In case of distal acinar or paraseptal, the proximal portion of the acini is normal and the distal portion is involved by emphysematous change. And the last one, that is irregular emphysema, here there will be irregularly enlarged acini. The acini will be irregularly enlarged and it is associated with fibrosis or scarring. So the four types of emphysemas are centriacinar, pan-acinar, distal acinar, and airspace enlargement with fibrosis. Now I will go through the pathogenesis of emphysema. At first, inflammatory mediators and leukocytes. Inflammatory mediators including leukotriene B4, interleukin 8, tumor necrosis factor and others are released by epithelial cells and macrophages. They attract the inflammatory cells from the circulation and amplify inflammation and cause structural changes. The next mechanism will be protease-antiprotease imbalance. Several protease enzymes are released from the inflammatory cells and epithelial cells that result in protease-antiprotease imbalance. As a result, there will be increased level of protease enzyme that ultimately break down the connective tissue component of the alveolar wall. So there will be destruction of the alveolar wall and there will be permanent enlargement of the alveoli. Then next one is oxidative stress. Substances in tobacco smoke, alveolar damage and inflammatory cells produce oxidants that cause more tissue damage and more inflammation. As a result of tissue damage, there will be destruction of the alveolar wall and dilation of the alveoli, which is known as emphysema. Then the last one is infection. Any kind of infection may exaggerate the emphysematous condition. This is a flowchart showing the pathogenesis of emphysema. We have already known that smoking or air pollutant along with genetic predisposition leads to oxidative stress, increased apoptosis and cellular senescence. There will be activation of inflammatory cells, release of inflammatory mediators and protease-antiprotease imbalance. On the other hand, if there is congenital alpha-1 antitrypsin deficiency, there will be added protease-antiprotease imbalance. As a combined effect, there will be destruction of the alveolar wall. Now pathogenesis. Hypothesis for destruction of alveolar wall is mainly protease-antiprotease mechanism and by imbalance between oxidant-antioxidant. So patient with a genetic deficiency of antiprotease alpha-1 antitrypsin, which is compounded by smoking. In case of pan-acinar emphysema, any stimulus that increases the number of leukocytes, mainly the neutrophil and macrophage, in the lung, which release protease containing granules and increase the proteolytic activities. So, in case of pan-acinar emphysema, there is congenital deficiency of alpha-1 antitrypsin. So, with low level of serum alpha-1 antitrypsin deficiency, elastic tissue destruction will be unchecked and as a result, there will be emphysematous change. Whereas, in case of centriacinar emphysema, the serum alpha-1 antitrypsin is normal Anti-protease hypothesis cause the development of emphysema due to effect of cigarette smoking. So we can see that in case of centriacinar emphysema, the main pathogenesis occurs due to cigarette smoking. So in case of smokers, what happens? Neutrophils and macrophages accumulate in the alveoli due to chemoattractant effects of nicotine and the effect of reactive oxygen species that are contained within the smoke. Then the accumulated neutrophils are activated and they release granules that are rich in cellular protease, for example elastase. Ultimately, these elastase cause tissue damage. Then what happens? The smoking also enhances elastase activity in macrophage. So macrophage elastase is not inhibited by alpha-1 antitrypsin. So in addition to elastase, matrix metalloproteinases are also derived from macrophages, and neutrophil have role in tissue destruction. So there will be a combined effect by various types of elastase and protease enzymes. Ultimately, there will be destruction of the alveolar walls and irreversible enlargement of air spaces. This is a photomicrograph showing the gross and microscopic appearance of emphysematous lung. This is the gross picture of lung in case of emphysema, and this is a microscopic picture showing the dilated alveoli and air spaces. Now we have discussed about emphysema. So what is emphysema? Mainly it is irreversible enlargement of air spaces distal to the terminal bronchiole. So in case of emphysema, there will be involvement of respiratory bronchiole, alveolar duct and alveoli. And there are 4 types of emphysema: centrilobular or centriacinar, panacinar, paraseptal and irregular type. And I have already discussed about the pathogenesis of emphysema. The main pathogenesis include tobacco smoking, and in case of panacinar emphysema, there is congenital deficiency of alpha-1 antitrypsin. Now we will discuss about the next type of obstructive lung disease, that is chronic bronchitis. Chronic bronchitis may be defined as persistent cough with sputum production for at least 3 months in at least 2 consecutive years, in the absence of any other identifiable cause. So there will be persistent cough with sputum production, and it will persist for at least 3 months in at least 2 consecutive years. It is common among habitual smokers and inhabitants of smoke-laden cities. Pathogenesis. The primary or initiating factors of chronic bronchitis is long-standing irritation by inhaled substances such as tobacco smoke. 90% of the patients are smoker. And there is dust from grain, cotton and silica. The earliest feature of chronic bronchitis is hypersecretion of mucus in the large airways that result from hypertrophy of the submucosal gland in the trachea and bronchi. Then protease is released from neutrophils. These include neutrophil elastase, cathepsin, matrix metalloproteinase. They stimulate this mucus hypersecretion. As chronic bronchitis persists, there is also a marked increase in goblet cell of small bronchi and bronchioles, leading to excessive mucus production that contributes to airway obstruction. Ultimately, there is sputum overproduction due to mucus hypersecretion. This is a picture showing the pathogenesis of chronic bronchitis. Here we can see the main factor is tobacco smoking. Then there may be presence of genetic mutations and infections. Ultimately, there is inflammatory stimulation. and there is smooth muscle hypertrophy, epithelial cell activation, and accumulation of inflammatory cells, mostly eosinophil. The clinical features include persistent cough production, which is productive, dyspnea on exertion. In chronic cases, there may be hypercapnia, hypoxemia, and mild cyanosis may develop. Long-standing severe chronic bronchitis may lead to cor pulmonale with cardiac failure. Even death may result from further complications. What may be the complications of chronic bronchitis? It may progress to COPD. COPD means chronic obstructive pulmonary disease, may lead to cor pulmonale and heart failure, and cause atypical metaplasia and dysplasia of the respiratory epithelium. And from dysplasia, there may be ultimately, in long-standing cases, there may be development of malignancy. So, thank you for today. In next class, we will discuss about the other types of chronic obstructive pulmonary disease, that are obstructive lung disease, then restrictive lung disease. Thank you.